I'm going to give it a couple minutes to get some people online. All right, we have a few more people here, so I'm gonna get started. You guys can hear me okay? Kind of just feels like I'm talking to myself, so. Right. So this talk is going to require some participation, so please be prepared to unmute, and it's going to be a little bit of a dialogue, so just kind of keep that in mind. Otherwise, I'm just going to start calling on people. But I'm going to get started. Hopefully people will join in, and I'm also recording the talk so we can, so people can kind of review it at a later time. So this talk is a little bit new to our residency program. We're going to be talking about communication in residency, and we thought that it was a good time to do this talk sort of at the beginning of the academic year to kind of go over some of the baseline expectations that the residency has on communication within our healthcare system. And we also, you know, the ACGME has a bunch of milestones surrounding communication, but there's no real way that we, in a formal way, educate you guys on how to communicate in a meaningful way. And so those were some of the reasons why we decided to give a little talk on communication during residency. Communication in healthcare can be very tricky. So oftentimes when you have good intentions on however you want to communicate with certain individuals in the healthcare system, it may not come off as how you intended. And oftentimes a lot of well-intentioned communication scenarios end up kind of going the wrong way. And I've seen it several times. I've experienced it myself, these similar situations that come up over and over and over again. And I've seen my trainees, even throughout my training, and colleagues and everyone kind of go through these situations over and over again. And just like how you guys have patients who come in like CHF exacerbations who you see over and over and over again, and as you do it over and over again, you learn how to manage them. It's a similar situation with communication, where you get into these communication issues that may occur over and over again. And if you have a little bit of a way to the tools to sort of navigate that, then when it comes up, you'll get better and better at it. So those are the reasons why we wanted to do a talk like this, okay? So before I get to the heart of the topic, the reason why I think this topic is so important is that patient safety is heavily dependent upon communication. So this report is a pretty famous report. It came out in 1999 to 2000. And it's a famous report that came out of the Institute of Medicine that revealed that a high number of deaths in healthcare are related to medical errors. Okay, and this is sort of where the patient safety movement and quality improvement movement started to gain steam. It was from this report. So when JCAHO investigated a bunch of these sentinel events, after this report came out, in a 5-year time period, they found that most of the sentinel events that occurred were due to communication errors. And so for these reasons, being deliberate about how you communicate within the healthcare system is really important. So a couple of things that I want to go over during this talk. I want to talk about communication related to availability and how to give the perception and actually logistically be available for communication. We're going to talk about a little bit of tips and tricks for communicating with consultants, where there's a lot of communication surrounding supervision. When you supervise an intern or when you're talking to your supervising attending, there's a lot of communication issues that can occur with that. And so we'll talk about a few tips on that. We'll touch a little bit on the logistics of family communication. That's a whole topic in and of itself on communicating with patients' families or talking about goals of care and things like that, but we'll touch on that. And then we'll talk about interdisciplinary communication within other healthcare professionals in the hospital or in your clinic, etc. Okay. So my disclaimer for this talk is that it is a bunch of random scenarios. It's not necessarily going to be a complete list of, what kind of situations that you may get into when you're in the hospital. But there are situations that I've seen happen enough that I think it's worth going over with you guys. The second thing about this talk is that, when I was putting this together, because this is new for me, I really wanted to give you guys a really nice evidence-based talk on communication in healthcare. And when I actually went through and looked at the literature, it's all over the place. People have written stuff that they've sort of like made up on algorithms and tips and things like that on communication in healthcare, but everything is different. There's nothing robust about what constitutes good quality communication. So really the stuff that I'm telling you is stuff from personal experience and from my observations and from the residency perspective on what we feel helps to get you guys into a better mindset for communication, okay? And a lot of times it's the baseline for how people perceive you as a professional. And so we wanted to give you the best tools to be able to handle those situations, okay? So that's the framework of the talk. So I'm gonna go over a few scenarios that have come up. These are real life scenarios. I've just tweaked medical details. And I would like you guys to consider the scenario and then tell me what you think the best thing to do in these scenarios are. And there's can be more than one right answer, okay? So this is our first scenario. So you are the night float resident, senior resident. A code is called overhead and you arrive at the patient's bedside to run the code. The critical care attending is there with you, supervising the code. You have been paged several times from the ER for what is likely an admission, and the code is lasting more than 30 minutes. What is the most appropriate action? A, you ignore the pages for now. You're managing a critical care issue, and you will call them after. B, you ask a nurse who's not participating in the code to call the number and let them know you are in the middle of a code and will call back. C, ask your intern to answer the page while you continue participating in the code. Or D, ask the critical care attending to take over the code while you answer the page. So someone tell me what they think a good option would be to handle this scenario.
Ask a nurse to return the page.
Ask the nurse to return the page. Okay. Anything else? Why not A? I mean, someone's like dying in front of you. Why not A?
I think it depends on how critical it is. And I mean, certainly it's critical, but if you can quickly let somebody know to return the page, it helps everything else flow. The rest of the hospital doesn't stop.
Yeah. Good. So, yes, you are dealing with a patient who is critically ill, and you have kind of an acute situation that's going on, but that pager is maybe the only way that the emergency room knows how to contact you for an admission, and they don't know what's going on. Like, they don't know that you're running a code. All they know is that you're not answering their pages. And so the best way is to get somebody else to get somebody to answer that page for you, and just let them know that this is what's going on and that you're happy to call later on. Okay, so I don't think that A is really sufficient, just because, like I said, it's going to cause a perception that your service is not available to handle whatever's going on in the emergency room. Okay, so I think B, C, or D, any of those options would be correct in this situation. Okay, and this isn't like, oh, this is the hard and fast thing that we're telling you, but it's going to help create a more professional environment and a more professional way that you run your service. Okay, so the first lesson in this lecture is that availability is essential to communication. You have to logistically and create the perception that you're available for communication. So in the limited amount of research that I was able to do for this talk, I did find some surveys that were done in the UK regarding communication in the hospital. And they surveyed a bunch of healthcare professionals to look at, how does, what things have helped in creating the perception that good communication is occurring. And remember, this is just the perception, and this is an opinion-based kind of study. But they wanted to see how moving from private docs admitting patients to the hospital to the hospitalist system, how that improved communication. And what they found, the themes that came out of those surveys, was that availability was key. So it was hard to get in touch with these doctors who are working outpatient because they're often seeing patients, may not call back right away, they're not physically in the hospital. And so the improvement in availability where a hospitalist was there right on the floor definitely improved the perception of improved communication. And then relationship building and a team-based approach were also other themes that came out of good communication within the healthcare system. So the ways that Erlanger specifically has tried to step up, and our program has tried to step up in terms of improving on communication is the implementation of Tiger Text. So before Tiger Text has been a lifesaver in terms of improving the availability of providers to anybody in terms of being able to be contacted for issues surrounding patient care. So that's certainly helped. I know 3000 has this, as well as the ICU, although that I don't know how regularly they're doing it with COVID, but interdisciplinary huddles have been implemented in certain floors where everyone gets kind of on board in terms of case management plans and patient care plans for the day. And it's a way for everybody to meet each other in terms of, this is the person that I probably will contact if I have a patient care issue for the day. And it just kind of helps to create that relationship building and teamwork approach that is important in communication. And then the implementation of the team pagers has also helped with the availability aspect for nursing, et cetera, for the teams. I wanted to take this opportunity in terms of, since we're mentioning Tiger Text, to kind of suggest to you guys to remember, you know, as we enter into an age where a lot of important conversations sometimes happen over text message in the world outside of healthcare, it can be easy to get into a habit of having long patient care related conversations over Tiger Text. And I want you guys to kind of be cognizant of the fact that there are some conversations that may work better over the phone or face to face, and to maybe use Tiger Text as a way to be like, hey, can you call me at whatever number, and I can help you with, so we can talk about this patient. And sometimes the communication will be better over the phone than over Tiger Text. So just to be cognizant of that, because I think as people get more like texting more for conversational purposes in healthcare, sometimes it's better to do it over the phone. So just be cognizant of that. Okay. And then the other thing about availability is being approachable. And so you can be logistically as available as whatever. You could be right there standing in the hallway of where all of your patients are at, ready and available to be communicated with. But if you're not, if you don't give the perception of being approachable, then that's not going to be helpful. And so this is kind of like the, you know, and that's going to be an individualized, you know, personality-based thing, but something to think about. You know, how do I, as a healthcare provider, be approachable for communication so that people aren't saying, you know, this person's really like not really somebody I like talking to because they don't seem approachable. So I'm going to have a higher threshold to call them for a critical patient issue. So you want to be approachable. And like I said, that's an individual sort of personal self-reflection process, but I wanted to make sure that you guys sort of thought about that. All right, so we're gonna do another scenario. Zoom things. Okay, so you are an ICU senior who has taken 2 admissions in the last hour to the resident service in the MICU, okay? Your 2 interns, so you have 2 interns on, and they're actively working up these patients. You get called about a GI bleed in the ER. The patient has had bright red blood per rectum, and the ER has transfused 2 units of blood. The patient needs to come to the MICU. Your attending has already decided that. GI has not been consulted yet, and you feel that they need to be reached sooner rather than later. So your options are, you can ask the interns to call the GI consult while they're working on the previous admissions before they've gone to the ER so that they can get in contact with them sooner rather than later. B, you call the GI consults and then go down to the ER so that you can get them contacted sooner. C, you ask the ER if they mind calling GI since they have already seen the patient. And D, you go down to the ER while the residents are working up the previous patients to see the patient briefly and then call GI. So someone tell me your thoughts on this. How about Javier? Javier?
Hey, this is Will. I would go see the patient and then call GI.
Okay, why?
Because we were consulted to see this patient, so it's important for us to do our own assessment, and then at that point assess the acuity of the patient, and then determine if the patient needs to have the GI consult, and then call them with knowledge of the patient and our own physical exam.
Good. I would argue also C is not wrong either. It would be within the scope of the ER to call the GI consultant since they've seen the patient and to kind of get the ball rolling while you're trying to get all your ducks in a row for your previous admissions and to go down and to see the patient. But I would say that C is also not not wrong. So I'm going to take this opportunity to talk about consultants and how you talk with consultants. So a consultant should never be called before you've seen the patient. So Will is exactly right. You have to make your own assessment for the patient. You need to be able to answer the questions that the consultant has when you call them and determine for yourself whether they really need a GI consult, and so, or whatever consult that you're calling for. So this is extremely important process in terms of talking with consultants. And I've seen residents who will call, and hospitalists now who will call for a consult before they physically see the patient. That's just considered poor form, okay? Other things that come up with consultants. So when you call for consults, it is really important to be clear on what your question is. If you're not clear about what your question is, then they may not address the issue that you're wanting answered for the patient, okay? So it's really important to be clear about your question. The other thing for consultant etiquette that I just want to put out there that I think is just professional is to call early in the day and be considerate about it. So just for your guys' knowledge, consultants have to see patients within 24 hours of getting the call unless it's something stat or urgent or whatever. That's a hospital policy. And so if it's something that you have no choice and have to call late in the afternoon, but is not emergent, be clear that, hey, I'm calling this consult, but, it's okay if you see them in the morning, and so it's good to be considerate about that. And obviously for urgent things that need to be called late in the day, that's obviously okay. But if there's somebody that you've taken over from, say, the overnight team who says, hey, this patient needs a cardiology consult for whatever reason, call in the morning. Don't wait until 4 o'clock to call them about a patient that probably needs to be seen that same day, okay? And you guys will all be consultants at some point in your lives too. Even if you don't do a subspecialty, you as a hospitalist will get consulted for, surgical patients and things like that. And so you want that kind of etiquette to be reciprocated. So things to consider when you're talking to consultants. So I wanted to go over an example of a call to a consultant. And so this is like something I've actually heard or received before. All right, so I have a consult for you. Hello? No. I have a consult for you. This patient is a 62-year-old man with a history of atrial fibrillation unpermitted who presents with dyspnea. He had dyspnea for 1 week, and then he noticed some blood in his stools. He went to his primary care, but by that time it had stopped. The dyspnea continued to worsen, and the patient then used 4 days later.
It sounds really good.
His hemoglobin was found to be 4.
I had a birth last year, so
thanks.
I need to.
Can you guys mute your phones for me?
I ended up buying a
You did?
with Angela.
Closer. I told you.
Can you guys mute your phones? Okay. So one of the interns, why don't you tell me what's wrong with this call?
Like I want to go they wanted like
How about Christian? Tell me what's wrong with this consult call.
somebody else, okay. So I ended up like settling for the one school. Yeah. So then it worked out because,
She's good. She knows it.
Okay, Christian? Okay. Any one of the interns, tell me what's wrong with this consult call.
There isn't a clear question
Okay, what else?
or the reason for the consult.
What else? there's a lot of unnecessary information, right? That they probably don't care about, like the dyspnea. So just try to be succinct is important. So here is an example of something that is a little bit better, right? So I have a consult for a GI bleed for a possible scope. He's 62 years old with atrial fibrillation on Coumadin, who comes in with hematochezia and a hemoglobin of 4. He's been transfused 3 units of blood and 2 units of FFP, and a repeat hemoglobin is pending. Wanted to see if and when you would consider endoscopy, right? So there's a question. It's succinct. It has the information that they care about, right? That they're on anticoagulation and what their hemoglobin was, what they've received so far, okay? So, you know, calling consultants takes practice. So as interns, take the opportunity to practice that, okay? And as senior residents, make sure that your med students and interns are getting feedback on how these calls are going, right? Because it's an important communication skill to be able to talk to another healthcare provider. Okay, any questions about consultants and talking to consultants? Okay. So let's go on to the next situation, which is going to talk about interdisciplinary communication. So you admitted a patient to the regular medical floor with sepsis from a UTI. After coming to the floor, the patient has become more hypotensive and tachycardic, and the nurse asks you to evaluate as he is concerned. You see the patient, they're awake and responsive. You feel that if you give them some fluids, this will all get better fairly quickly. But the nurse states that he is very concerned about the patient staying on the regular medical floor and thinks that the patient needs to be transferred to the ICU. What do? A, ask the nurse to give fluids and you will reevaluate. B, ask the nurse to give fluids and you will speak with your, and you will call a rapid response. C, ask the nurse to give fluids and you will speak with your attending. D, ask the nurse to give fluids while you speak with your attending and then make you attending for possible transfer. What do you guys think?
I think D is the most appropriate answer in this setting because you accomplish several things. You're trying to treat the patient with fluids. You are communicating with the proper individuals, the attending, the medical ICU attending. You're also addressing the nurse's concerns about a patient's stability on the floor by talking with the MICU attending as well.
Yeah, I agree. Does anyone else have any other comments about the other choices?
I can't see the other choices.
I mean, C is not wrong too. I mean, if the patient is not septic, why would we involve another specialty into the mix?
Okay. Anything else? Why not B?
I mean, we don't have vitals, to be honest. Yeah, so I'm not really sure.
Okay, whatever. The heart rate's 130, let's say that. So, and the blood pressure is 80/50.
So yeah, maybe B will be more appropriate at this time then.
So there are multiple right answers to this, okay? All of those would be correct. I would say that maybe A might not be enough. You could do it, depends on the scenario. I made the scenario up, but it's happened before in some capacity. A lot to me, to multiple residents, and it gets people into trouble because a lot of times you feel like you can take care of a patient on the floor, you have the medical knowledge, you know what's happening, you're not worried about it too much, but your nurse is worried about it. And so I think that the if the case is that your nurse is that worried about a patient, that you need to escalate in some way, because that's how they're expressing their concern about the patient, that they can't take care of that patient on the floor. And I think that it's important to realize that when these situations comes up, and it comes up a lot. It comes up a lot where you have a patient who somebody's not comfortable taking care of on the floor, but you may be fine with it. You have to remember that this taking care of these patients are a teamwork approach, and you don't know what that nurse is dealing with in terms of the other patients that they're taking care of. You know, Erlanger's notorious for having a high patient to nurse ratio, and that even just giving some fluids and rechecking blood pressure a little bit more frequently for a couple of hours is too much for that nurse. And so they need help, right? Or they need help and an escalation of some sort. So calling a rapid response would not be a bad call, because it gets other nurses to the bedside to help that nurse, and it helps them give an assessment from the nursing perspective on, does this patient truly need a transfer to the ICU, or will they be like, hey, we'll hang out with you while we give the fluids, and if everything is fine, we'll keep the patient on the floor. All right, so rapid response is a great solution to something like this. Speaking with your attending is a great solution as well, because it allows the nurse to realize that you are escalating the situation. You're not just saying, oh, it's fine. You're escalating and talking it through with somebody else. And then obviously, depending on the situation, you can also ask about a possible transfer if you feel like it would just be better to just transfer the patient, depending on how the nurse seems to be in terms of the level of concern. But the point of this situation is that if the nurse is concerned, you need to do something about it. You can't just deal with the medical issue and then move on, okay? So the lesson from this is that your nurse or whatever healthcare provider that you are dealing with, always have the baseline assumption that they know more than you, okay, about what they're dealing with. And to be honest, it's true. Regarding their line of expertise, they have been working longer than you, and they know more about their about that type of part of the teamwork approach of medicine. And to keep that in mind when you're dealing with other healthcare professionals within the hospital. And if you come from that place and that type of mindset, the communication is going to go much smoother, regardless of whether or not that person is correct, okay? And it's tricky because, you know, we're trying to train you guys to be leaders of the healthcare team, but at the same time, you're relatively at the beginning of that process. And so just remember to have some humility in those conversations, and remember that if someone else is concerned, you need to take that concern seriously, okay? And so that will keep you out of trouble. It'll keep the interaction more pleasant for everybody. And honestly, you know, if you have more of those pleasant communication scenarios, you'll have less burnout when working in general, okay? So keep that mindset that the person that you're working with knows more than you, and it will be solid for your career. Okay, so I wanted to take, it's a little slightly off topic, but I wanted to take this opportunity to kind of show you guys that, you know, when nursing communicates with you, they are trained to be, to communicate in a certain way, right? And so their way of communicating is through SBAR, which they kind of go through. So when they're talking to you, they're going to talk to you in that using that type of tool. They're going to tell you about the situation. So this patient is so-and-so who's here for a urinary tract infection, and he's hypotensive. Patient hasn't received any fluids yet. My assessment is that they're going into septic shock, and I think this patient needs to go to the ICU, okay? So if you look at the SBAR, the last part is a recommendation. So I've had people get a little bit offended when people say something like, oh, I think this needs to happen with the patient. But you have to remember that that's how they're trained to communicate to healthcare providers, is to give a recommendation what they think what the patient needs. And so if you remember that that's how they're trained to communicate, then you don't take it as badly as, you know, as if they're challenging you or something like that. Okay. And so that's why I wanted to kind of put that out there, is that this is how they train to communicate with healthcare providers. Okay. And so just to keep that in mind. For instance, so we also have ways to communicate with each other, right? And we use iPass, which I won't go over in detail right now, but that's sort of our equivalent communication tool for communicating with each other. But it just goes to show that, you know, we learn how to communicate differently than from nursing. And so just keeping those things in mind is really important. Okay, so next scenario. So you are a new PGY2 in the MICU on at night. You have done 7 to 8 central lines. You're admitting a patient that's severely dehydrated with a normal blood pressure. The ER states that they could not get a peripheral IV and had to place a central line. The line was very difficult. The patient's dehydrated, took multiple sticks, and they're not sure how sterile the procedure was. Your MICU attending is having a busy night. When you staff the patient and mention the central line issue, your attending states that the central line needs to be changed over a wire tonight. While you know how to place a central line, you have never changed a line over a wire. Now, just ignore the fact that some people don't think that's a very sterile thing to do, okay, guys? Your attending does not have time to directly supervise you right now, but assumes you can do it on your own because you're signed off on central lines. How do you respond? You try to do the procedure. You tell your attending that you don't feel comfortable doing the procedure without supervision since you have never done it before and can wait for them to be available since it's not emergent. Ask the attending if you can pass it on to the day team since you're not comfortable doing the procedure without supervision. Or D, wait until the morning and tell the day team you didn't get around to it. What do you guys think?
I would say
B.
B. Yeah.
B, why?
I think if I try to do a procedure that I've never done without appropriate supervision, I think I'll probably do more harm than good. And if it's not something I'm not comfortable with, I'd rather have some supervision doing it, and just not do it on my own, just because attending said we need to have it done.
Okay, good. Yeah. C would be okay too if it really truly was a busy night and, you know, this patient has access. It does need to be changed, but does it need to be changed right that second? Maybe not. And so C would probably be okay too, but B is probably the better answer. D is not good because that means you just didn't communicate with anybody. So that's poor form. And then A, definitely. If you're not comfortable, you shouldn't do it. Okay, so I'm going to talk a little bit about supervision. So if you feel that you need supervision, ask for supervision. So I purposely made that scenario a little bit of a gray area because technically that resident is signed off on central lines. So why can't they change it over a wire? It's not that different, right? But things can go wrong when you even just changing something over a wire. And so I think that, you know, we've had situations where residents have been asked to do things where it's been kind of a gray area in terms of supervision and things like that. If you don't feel comfortable, you need to communicate that. And that's okay. And it doesn't mean that you're weak, and it doesn't mean that you are not going to get trained because you asked for help. You'll still get to do whatever you need to do. You'll just be supervised properly. Okay, so make sure that you never feel that you can't ask for supervision because that's what you're here for. Okay. So how to be supervised. So let me I'm going to quickly go over because you guys can read this on your own, but this is straight out of the manual. the residency manual on what interns and what senior residents need, when they need to be supervised, and how they for what different scenarios. Okay, so for interns, it's fairly simple because for the most part everything needs direct supervision. But for upper levels, I wanted to point out this middle column, which is the indirect supervision with direct availability but a verbal discussion, because I think sometimes that people have different practice patterns on that, but it really should, if you're putting someone on a pressor or giving someone amiodarone, like really should require a heads up to the attending. Okay. And then the other thing that changed over the last 2 years was endotracheal intubation always requires direct supervision, no matter how many you've done. Okay. Okay. And then this is the straight out of the manual on what requires attending contact. Okay. So I won't spend too much time on that. Okay, so this is another scenario related to supervision. So you are the PGY2 on at night with an intern. Your intern appears to be struggling with admissions. Okay, you've already received 5 and the H&Ps are only completed on 2 of them. Orders have been completed on 4 of them. It's 4 a.m., the day team will be here in 2 hours, and you want all the work to be completed so that both you and the intern can leave on time. A few sick patients need to be checked on as well. So which of the following would you do? A, keep reminding the intern that their shift is finishing up and the notes and orders need to be done. B, take a quick break to assess the residual work and divide it up so that it can be accomplished in a timely manner. C, tell the intern that you will see all the patients and do all the notes because you can get them done faster. That's the right answer. Someone talk.
I would like to say A, but the real answer should be B.
Okay, why would you like to say A?
No, that was just a joke aside. I think as an intern myself, when I was overwhelmed with stuff, it was nice to have the upper try to help out in a way that we can do things more productively and get it done instead of having the intern do everything.
Okay. Well, let me be devil's advocate. Well, what if someone's like, well, how does the intern learn then if they don't do everything?
Well, how they gonna learn if they're overwhelmed? That's a problem.
Mm-hmm.
I mean, it is good to learn if you have a lot, but it's impossible to learn when you have 200 things to think about.
Okay, good. Yeah, that's sort of the point I wanted to make on this, because I've seen senior residents do both of those wrong things. Okay, so it is not right to just take over and do everything, right? That's completely not conducive to training. But it's also not an expectation to just have the intern do everything and that there's no slack picked up from the senior resident. So what I wanted to talk about from this scenario is that, as an upper level resident, you are also still in training and you're training to be an attending, right? That's your next direct step, or fellow, whatever, but still you're training to be an attending. And so you're ultimately responsible. You should act like you're ultimately responsible for all patient care. So that means that you're not above writing notes if your intern hasn't gotten to it and won't get to it in a timely manner, doing a presentation, reviewing orders, reviewing discharge orders, all that stuff, because you're ultimately, should be responsible for everyone's patient care, because next year you'll be the attending who's responsible for all the patient care, right? And so I think we see variable levels of ownership when it comes to that with senior residents. And I think it's really important to remember that you need to be able to pick up the slack when your intern can't do it. And it doesn't mean that there's something wrong with your intern. It's a process of graduated responsibility, right? And so initially they may not be able to, but the expectation is over time that they'll be able to handle more and more stuff as time progresses. So it's a balance between patient care and education, but patient safety and patient care is your number one responsibility. Then the education is number two. Okay. And so I struggle with this still, right? How much do I do on my own versus let you guys do stuff? And it's a lifelong process. So I'm not saying that magically as you're in upper year, you're going to know where that balance is, but just I like you guys to be cognizant that there is a balance and to remember and to purposely choose where your line is. I think it's better that way than just being oblivious to it. Okay. So, you know, another example is that if you're in the ICU and your intern didn't get to see one patient, you should be able to pinch hit and do a simple presentation for that patient because you were responsible for that whole team. Okay, so those are examples. Anyone have any thoughts on that? Anyone disagree? Okay. All right, good. All right, so we have a little bit of time left, so let's see. Next scenario, so your colleague is taking an admission from the ER to the ICU. The attending who accepted the patient states that they're intubated and may be brain dead according to the ER. The patient's hemodynamically unstable, okay? The resident feels that they should see if the family wants to transition to comfort care sooner rather than later because it's going to change their management drastically. They call the family before heading down to the ER. Would you have done the same? It's a little bit related to another scenario we had earlier.
I think that's probably somewhat worse than calling a consultant without having seen the patient.
This has happened, by the way. This has happened to me. This is something that I've seen happen.
I mean, if it were my family member in the emergency department, I wouldn't want to be called by someone to have that particular conversation if that person had never even laid eyes on or touched my family member.
Yeah, correct. Good. I mean, you don't even know if the patient's actually brain dead, right?
Correct.
Yeah, right. Okay, good. In kind of the same, so I just wanted to make sure you guys understood that because I have seen that happen recently. So you don't talk about change in management, goals of care, things like that until you've actually seen the patient. And I'll just leave that at that. And then go over sort of kind of in the same theme scenario. So you're admitting a patient during the day with metastatic thyroid cancer who has neutropenic fever. You feel that this patient should not be a full code. You heard she was a full code from the ER and have not asked yourself yet. You staff the patient with your attending, and other than mentioning that the patient is full code, there's no other discussion during your rounds. So what do you do next? Do you go talk to the patient about goals of care and code status and then tell the attending the next day on rounds that the patient wants to go home with hospice and be DNR? B, ask your attending if they think it is appropriate for you to have a goals of care discussion and how far and limitations of care would be appropriate. C, since you didn't talk about it on rounds, leave the patient a full code. D, speak with the patient's oncologist regarding what they feel that patient's prognosis is. Update your attending on this and use this to frame your goals of care discussion. What do you guys think? There are multiple appropriate answers. Okay, Stacy, what do you think? Hopefully Stacy has a microphone.
I think that the last D sounds the most appropriate, because that way you can speak with the oncologist and see what the goals of treatment are, what treatment the patient's actually receiving. And then depending on what the oncologist says, you can have a more realistic conversation with the patient.
Yeah. Yeah, D is probably the most right answer, but B is okay too. B is okay too. The point is involving your attending in the situation. C is not, I mean, you could do C, but if you felt like the patient doesn't need to be shouldn't be full code, then you should pursue it. You know, your opinion matters in that. And so I think that's probably not the best thing to do if you feel like the patient shouldn't be full code, or that you haven't addressed it yet. A is not appropriate, and the whole point of the scenario is that this is a, you know, when you're talking about goals of care, and your intent is to change it, right? You really should notify your attending, or at least make them aware that that's what you're doing. Okay. I've had colleagues who've had residents who've gone and said, you know, your prognosis is poor. You know, there's not going to be any treatments or whatever, so something to that effect, and made a patient DNR, and later to find out that they actually have decent treatment options, and that, you know, the prognosis may not be poor. And so it becomes really confusing and devastating for the family. And so just to make sure you understand sort of what the steps are to take to have a significant goals of care discussion with the family member. You know, goals of care discussions are a skill, just like doing a procedure, right? There is a way to go. There's a systematic approach to doing it. There is skills and tricks and tips that people have and learn to do goals of care discussions. So it requires practice, and you should treat it just like a procedure. And so you would never do a central line on somebody without letting your attending know, and the same thing with goals of care discussion. But that doesn't mean that you shouldn't do the goals of care discussion, because it requires practice. So it's just something to keep in mind. Goals of care discussions are a talk on their own, etc. But I just wanted to make sure that people have that framework and mindset that a goals of care discussion is something that you are also being trained into. So just keep that in mind. All right, so that's all I have for you guys. You know, try to remember that you want to be available and approachable for communication, because it's going to help people come up to you and tell you when things are going wrong. You know, you want to make sure that you're aware of everything that's going on with your patient. Be aware that there's etiquette involved with talking to consultants, because, you know, when you're the consultant, you want that same etiquette returned back, okay? Supervision is tricky, okay? But you shouldn't do anything that you're not comfortable with, okay? You should always assume that your nurse or whoever you're talking to, physical therapist, respiratory therapist, whoever, is correct in their assessment. And then if you start with that assumption and then work with that, it'll keep you out of trouble, okay? Never talk to a family or a consultant before seeing a patient, and seeing a patient yourself. And remember that this whole communication thing is not to make you more anxious or nervous about talking to people. It's just to help you keep patients safe, to be successful professionals, keep you out of trouble, and to have a positive residency experience. Because if you have positive communication with people and positive interactions, I do feel it helps to mitigate burnout related to the workplace. So that's all I got. What questions do you guys have or comments? Okay, well, I will.
Dr. Shah, thank
Yeah.
you so much for doing this lecture. It's really helpful.
Okay, good. Good, I'm glad. And if anything ever comes up in your guys's like practice or whatever, where you feel like something didn't go the way that you wanted it to go in terms of a communication encounter, you know, feel free to get feedback also from me or your attendings about how you could have done things differently. That's the only way to get better in that respect. Okay. All right, guys, well, have a good day, and I will see you guys soon.